So this is your student nurse Lhester. For today's video, I'll be making a new video, and that video that I'll be making will be all about prostate cancer. So, disclaimer, this video is for learning purposes only. So, let's go.
So, prostate cancer. So, cancer is a disease process whereby cells proliferate abnormally, ignoring growth-regulating signals in the environment surrounding the cells, according to Sutter and Brunard from the Medical Surgical Nursing textbook. So, before we delve into the discussion, we will tackle all the introduction, overview of the male reproductive system, definition, risk factors, pathophysiology, clinical manifestation, assessment and diagnosis, laboratory and diagnostic procedures, management such as medical, pharmacologic, and surgical management, nursing diagnosis, nursing management, or responsibilities, and lastly is the prognosis. So, a prostate cancer is a slowly progressing disease. Many men die of old age without ever knowing they have it. Prostate cancer is caused by changes in the DNA of prostatic cell. So, the structures in the male reproductive system include the external male genitalia consisting of the testis, epididymis, scrotum, and penis, and the internal male genitalia consisting of the vas deferens or the ductus deferens, ejaculatory duct, and prostatic duct, and membranous sections of urethra, seminal vesicles, and certain accessory glands such as prostate gland and Cooper glands or the bulbourethral glands. So, the prostate gland is lying just below the neck of the bladder, is composed of 4 zones and 4 lobes. It surrounds the urethra and it is traversed by the ejaculatory duct, a continuation of the vas deferens, and this gland produces a secretion that is chemically and physiologically suitable to the needs of the spermatozoa on their passage from the testis. Cooper glands lie below the prostate within the posterior aspect of the urethra, and this gland empties its secretions into the urethra during ejaculation, providing lubrication. So, the prostate cancer is marked by an uncontrolled malignant growth of cells in the prostate gland. The prostate is a walnut-sized gland in men located just below the bladder and in front of the rectum, surrounding the urethra, the tube that carries urine out of the bladder. And the risk factors of the prostate cancer is the increasing age of 50 to 65 years old, obesity, and smoking, excessive alcohol intake, and the diet, especially in men who consumes excessive amounts of red meat, animal fat, dairy products that are high in fat. Also, the family history, which is in men who have father or brother previously diagnosed with prostate cancer or tumor, and man with lower levels of vitamin D, and experience prostatitis, and the elevated blood levels if testosterone. So, the pathophysiology of prostate cancer is, in prostate cancer, the cells of these prostate glands mutate into the cancer cells, and the mutation is majorly in a p53 gene or a tumor protein, also known as p53 or the antigen p53, and a BCL2, a founding member of BCL2 family of regulator proteins that regulate cell death by either inhibiting or inducing apoptosis. And ERK5 or the alteration in AKT kinase is a protein, a member of mitogen activated protein kinase. And an AKT kinase B is also known as AKT, is a serine threonine specific protein kinase that plays a key role in multiple cellular processes such as glucose metabolism, apoptosis, cell proliferation, transcription, and cell migration, which signaling that contribute toward the development of prostate cancer. And the prostate gland requires hormones known as androgen that are involved in cell survival and apoptosis. And the androgen include testosterone, dihydrotestosterone, and dihydrotestosterone, cause and initially small clumps of the cancer cells remain confined to prostate glands, a condition known as carcinoma in situ or prostatic intraepithelial neoplasia. And this leads to cancer begins to multiply and spread to the surrounding prostate tissue, forming tumor, and that tumor may grow large to invade nearby organs such as nearby lymph nodes or the rectum, or metastasize the bone, lymphatic system, and bladder. So, majority of tumor occur in the outer aspect of the prostate gland and peripheral zone of the prostate gland, and the prostate cancer is usually slow growing, and it can be spread by mainly three routes: by direct extension, through the lymph nodes, through the bloodstream. And if prostate cancer spread through direct extension involves the seminal vesicle, urethral mucosa, bladder wall, and external sphincter, the cancer later spreads through the lymphatic system. So the clinical manifestation is a weak or interrupted urine flow, that the urinary obstruction occur in advanced disease. If the cancer is large enough to encroach the bladder, neck, signs and symptoms of urinary obstruction occur: difficulty and frequency of urination, retention, and decreased size of force of the urinary stream. And could cause also blood in urine or hematuria. That other symptoms may include in blood in the urine of semen and painful ejaculation, and it occurs if the cancer invades the urethra or the bladder. And it also cause nocturia and dysuria. It also cause a pain in pelvis, spine, and ribs. The prostate cancer can spread to lymph nodes and bones. Symptoms metastasize include backache, hip pain, perennial and rectal discomfort, anemia, weight loss, weakness, nausea, oliguria or the decreased urine output, and spontaneous pathologic fractures, lymphedema, renal insufficiency, and last is sexual dysfunction is common before the diagnosis is made. So the assessment and diagnostic findings are history collection, physical examination. If prostate cancer is detected early, the likelihood of cure is high. It can be diagnosed through an abnormal finding with DRA, serum PSA, and ultrasound-guided TRUS with biopsy. Detection is more likely with use of combined diagnostic procedures. The diagnosis of prostate cancer is confirmed by histologic examination of tissue removed surgically by TURP, open prostectomy, or ultrasound-guided transrectal needle biopsy. Fine needle aspiration is a quick, painless method of obtaining prostate cells for cytologic examinations and determining the stage of the disease. So the DRE, or the digital rectal examination, is useful in ruling out prostate enlargement caused by benign prostatic hyperplasia. So the routine repeated DRE preferably by the same examiner. It is important because early cancer may be detected as nodule within the gland or as an extensive hardening in the posterior lobe. The more advanced lesion is stony, hard, and fixed. The RE also provides useful clinical information about rectum, anal sphincter, and quality of stool. Next is the prostate-specific antigen blood test, or the PSA. It's a protein produced by prostate gland. With all men have a small amount of PSA in their blood, and it increases with age. Prostate cancer can increase in production of PSA, and so a PSA test looks for the raised levels of PSA in the blood that may be a sign of condition in early stages. So the PSA level should be below 2.5 mostly, but the PSA levels up to 4.0 nanogram per ml is considered normal. And note that if PSA level is very high, cancer has probably spread beyond prostate. So next is the transrectal ultrasound. It's also called as the prostate sonogram or endorectal ultrasound, that used to look at the prostate and tissues around it. Next is the MRI or the CT scan and bone scan, to access the extension into the bladder and lymph nodes for staging and cancer and evaluate bone metastasis. The bone scans and skeletal x-rays and the MRI may be used to identify metastatic bone diseases. So pelvic computed tomography may be performed to determine if the cancer has spread to the lymph nodes, and the radiolabeled monoclonal antibody capromab peptide with indium 111 or the Prostacent is an antibody that can be used to detect either recurrent prostate cancer at a low PSA levels or metastatic disease according to NCCN 2008. So the biopsy is an aid in diagnosis and help to determine the Gleason score. So the biopsies are examined by pathologists to both determine if cancer is present and to grade the tumor. The most commonly used tumor grading system is the Gleason score. The system assigns a grade of 1 to 5 for the most predominant architectural pattern of the glands of the prostate and secondary grade of 1 to 5 to the second most predominant pattern. So the Gleason score is a sample tissue from the biopsy are studied in a laboratory, and if cancerous cells are found, they can be studied further to see how quickly the cancer will spread. A Gleason score of 6 or less than means a cancer is unlikely to spread. Then a Gleason score of 7 means there is a moderate chance of the cancer spreading. And a Gleason score of 8 or above means there is a significant chance the cancer will spread. So this is the Gleason pattern scale, which is in grade 1 termed as small or uniform in glands, and in grade 2 there is more space or stroma between glands, and in grade 3 there is distinctly infiltration of cells from glands and margins, and in grade 4 there is irregular masses of neoplastic cells with few glands, and grade 5 there is a lack of occasional glands, sheets of cells. And the medical management of prostate cancer is treatment-based, is on the patient's life expectancy, symptoms, risk, recurrence after definitive treatment, size of the tumor, Gleason score, PSA level, likelihood of complications, and patient's preference. And based on the stage of the disease, tumor's size, patient's age, general condition, severity of the symptoms, and level obstruction of urine flow system. So the complications would be hemorrhage and hypovolemic shock, infection, DVT or deep vein thrombosis, pulmonary embolism, and sexual dysfunction. So the objectives of medical management would be to reduce the symptoms associated with prostate cancer and cure if in its early stage, improve the quality of life, and to prevent complications associated with prostate cancer and its treatment, and to improve sexual life. So there were collaborative therapy such as watchful waiting with annual PSA and DRA. Number 2 is the radical prostectomy. It is complete surgical removal of the prostate, seminal vesicles, tip of the vas deferens, and the often surrounding fat nerves and the blood vessels. Laparoscopic radical prostectomy and robotic assisted laparoscopic radical prostectomy have become the standard surgical approaches for localized cancer of the prostate. Although sexual impotence is a common side effects, this laparoscopic radical prostectomy approaches result in a low morbidity and more favorable postoperative outcomes, including improved quality of life and less sexual dysfunction if the nerves are spared. So, radical prostectomy is a common approaches for radical prostectomy has two kinds. It is the retropubic radical prostectomy and the perennial radical prostectomy. Next is the resection therapy, which is two types also. That is teletherapy or the external beam radiotherapy, a radiation directed towards the whole pelvis externally. Then it also called as EBRT, that it may be given for 5 days per week for 7 to 8 weeks. It is a treatment option for patients with low-risk prostate cancer. Progression-free survival is similar to the low-risk patient treated with radical prostectomy. So next is the brachytherapy or in radioactive seeds. These tiny radioactive seeds that are placed in the body close to tumor. And the brachytherapy is an internal implant, involves the implantation of interstitial radioactive seeds under anesthesia. It has become a commonly used monotherapy treatment option for early and clinically organ-confined prostate cancer. The surgeon uses ultrasound guidance to place 80 to 100 seeds depending on the prostate volume, and the patient returns home after the procedure. Brachytherapy may be combined with EBART with or without neoadjuvant androgen deprivation therapy for patients considered in intermediate risk. High-risk patients are considered poor candidates for permanent brachytherapy. So, possible effects of radiation therapy. It causes erectile dysfunction because radiotherapy can affect the nerves surrounding the prostate and controls man's erection. And the urinary problems. Radiotherapy does not usually cause urinary incontinence, but sometimes it may cause a narrowing of the urethra, which may then cause difficulties passing urine. And next is the bowel problem, that radiotherapy can cause inflammation to the lining of the rectum in a small percentage of men, and it may cause bleeding form that back passages of need to go to the toilet to pass stool more frequently. So, another therapy is hormone therapy. The goal is to reduce the levels of hormones called androgens in the body, or to prevent them from reaching prostate cancer cells. There are different types of drugs that lower testosterone. One is the luteinizing hormone, or the LH blockers. Stops pituitary gland making the hormone so that the testicles don't receive the message telling them to make testosterone. These are the leuprolin, relin, glycerylin acetate, buserelin, triptorelin, and hysterelin. And it is injected or implanted under the skin. So, anti-androgens stop androgen from working by binding the receptors and stop testosterone to bind with receptors so that the cancer can't able to grow. With the help of bicalutamide, flutamide, and the enzalutamide, which is an anti-androgen treatment, may be combined with the LH blocker as first-line hormone therapy. So, another is the triple androgen blockade, or also known as TEB. Some doctors have suggested taking combined therapy one step further by adding a drug called a 5-alpha reductase inhibitors, such as finasteride, dutasteride, and a combined androgen blockade. Next is the enzalutamide, which means a androgen bind to the androgen receptor. That receptor sends a signal for the cells to grow and divide. Blocks the signal form of androgen receptor to the cell. Next is the abiraterone, or the Zytiga, that recent advances have demonstrated that androgen-based pathways continue to have clinically significant role in the progression of castrate-resistant prostate cancer. Another is the chemotherapy, sometimes used in prostate cancer, has spread outside the prostate gland, and hormone therapy isn't working. So for prostate cancer, chemo drugs are typically used one at a time. Some chemo drugs used to treat prostate cancer includes as docetaxel, cabazitaxel, doxorubicin, etoposide, vinblastine, paclitaxel, and carboplatin. So, in chemotherapy, the treatment in combination with conventional therapies may play a future role in treatment. Gene-based therapy in prostate cancer is an emerging and promising adjuvant to conventional treatment strategies. Complications related to chemotherapy are specific to the type of chemotherapy administered, such as a radium-223 dichloride or the Xofigo, to treat certain men with advanced prostate cancer, and it is intended for men whose cancer has spread only to their bone, and it is given as injection in vein once a month. So the last one is the vaccination of Cipleosil T, or the Provenge, is a cancer used to treat advanced vaccine used to treat advanced prostate cancer. So these vaccines aim to treating prostate cancer, not preventing it. So the other therapies includes the cryosurgery of the prostate. It's used to ablate the prostate cancer in patients who cannot tolerate surgery and in those with recurrent prostate cancer. Transperennial probes are inserted into the prostate under ultrasound guidance to freeze the tissue directly. Keeping the urethral passage patent may require repeated TURPs. So, in bone lesions that results from metastasis of prostate cancer can be very painful and result in a pathologic fractures. And opioid and non-opioid medications are used to control bone pain, and EBRT can be delivered to skeletal lesions to relieve pain. And radiopharmaceuticals such as strontium and samarium can be injected intravenously to treat multiple sites of bone metastasis. Another is the anti-androgen that therapies are used in an effort to reduce circulating androgens. If androgen therapies are not effective, medications such as prednisone have been effective in reducing pain and improving quality of life. And next is the biphosphate therapy with pamodronate or aradia can be administered to reduce the risk of pathologic fracture. In advanced prostate cancer, blood transfusion are administered to maintain adequate hemoglobin levels when bone marrow is replaced by tumor. So, a patient undergoing prostate surgery. Prostate surgery may be indicated for the patient with BPH. A prostate cancer. The objectives before prostate surgery are to assess the patient's general health status and establish optimal renal function. Prostate surgery should be performed when acute urinary retention develops and damages the upper urinary tract and collecting systems, or in case of the prostate cancer before cancer progresses. So, what is BPH? BPH is a benign prostatic hyperplasia. Surgical procedures. Approaches can be used to remove the hypertrophied portion of the prostate gland. TURUP, Suprapubic Prostectomy, Perennial Prostectomy, Retropubic Prostectomy, and TUIP. And Laparoscopic Radical Prostectomy and Robotic Assisted Laparoscopic Radical Prostectomy. So, first is the transurethral resection of the prostate or the TURP. The most common procedure used can be carried out through endoscopy. The surgical and optical instrument is introduced directly through the urethra to the prostate, which can then viewed directly. Then the gland is removed in small chips with an electrical cutting loop. So, the procedures eliminate the risk of transurethral dissection syndrome, that is hyponatremia and hypovolemia. Urethral dissection syndrome is a potential but rare complication of TURP that occurs in approximately 2% of men who undergo the procedure. And TURP rarely causes erectile dysfunction but may trigger retrograde ejaculation. Because a removal of prostatic tissue at the bladder neck can cause the seminal fluid to flow backward into the bladder rather than forward through the urethra during ejaculation. So next is the suprapubic prostectomy. In suprapubic prostectomy, an incision is made into the bladder and the prostate gland is removed from above. And such an approach can be used for gland of any size, and few complications occur although blood loss may be greater than with other methods. And another disadvantage is the need of abdominal insertion, which has a high risk of associated with any major abdominal surgical procedure. Next is the perennial prostectomy. So, in perennial prostectomy, the prostate gland is removed through an incision in the perineum. This procedure is practical when other approaches are not possible and is useful for an open biopsy. However, incontinence, sexual dysfunction, and rectal injury are more likely with this approach. Next is the retropubic prostectomy. So, it is used more commonly than suprapubic approach. The surgeon makes a low abdominal incision and approaches the prostate gland and between the pubic arc and the bladder without entering bladder. So, the procedure is suitable for large glands located high in the pelvis. Although blood loss can be better controlled and the surgical site is easier to visualize, infection can readily start in the retropubic. The transurethral incision of the prostate. It is another procedure used to treat BPH. An instrument is passed through the urethra. TUIP is indicated when prostate gland is small, 30 grams or less, and it is an effective treatment for many cases of BPH. TUIP can be performed on an outpatient basis and has a lower complication rate than other invasive prostate procedure. Laparoscopic radical prostectomy. In contrast to the single abdominal incision made for radical prostectomy, a laparoscopic radical prostectomy is performed through 4 to 6 small 0.5 inch or 1 cm incision in the mid-abdomen. Instruments including a lighted viewing instrument or laparoscope are inserted and allow the surgeons to remove the prostate gland. So, the laparoscopic approach reduces the risk of postoperative erectile dysfunction and urinary dysfunction. Laparoscopic radical prostectomy results in less bleeding, reduced need for blood transfusion and a shorter hospital stay, less postoperative pain, and more rapid return to normal activity compared with open radical prostectomy. Next is the robotic assisted laparoscopic radical prostectomy. It's a new minimally invasive approach that uses computer console and Da Vinci robot to move the tips of microscopic instruments, replicating the movements of the surgeon's hand. Last is the pelvic lymph node dissection, or the PLND. Is not always performed, but it may be used in some patients to provide information for staging a tumor and to remove an area of microscopic metastasis. The planned treatment may influence the surgeon's decision to perform PLND and the extent which is limited versus extended, or of the dissection. The dissection of nodes anterior and lateral to the external iliac vessels is associated with an increased risk of lymphedema, which is according to NCCN 2009. So the complications of postoperative complications depend on the type of prostatectomy performed and may include hemorrhage, clot formation, catheter obstruction, and sexual dysfunction. All prostatectomies carries a risk of impotence because of potential damage to the pudendal nerves. In most instances, sexual activity may be resumed in 6 to 8 weeks, the time required for prostatic fossa to heal. During ejaculation, the seminal fluid goes into the bladder and is excreted with the urine. The anatomic changes in the posterior urethra lead to retrograde ejaculation, and a vasectomy may be performed during surgery to prevent infection from spreading from the prostatic urethra through the vas and into the epididymis. After total prostatectomy, the risk for impotence is high. For the patient for whom this is an acceptable option, are available to produce erection sufficient for sexual intercourse, such as prosthetic penile implants, negative pressure vacuums, devices, and pharmacological interventions. So the nursing managements are the nursing assessment, history collection, physical examination regarding presenting urinary problems, voiding functions, UTI, urinary retentions, dysuria. Obtain family history of prostate cancer. And last is the nutritional assessment and lifestyle. The diagnosis in a pre-operative patient of prostate cancer is based on assessment data. The patient's major nursing diagnosis may include the following: anxiety about surgery and its outcome, acute pain related to bladder distension, deficient knowledge about factors related to the disorder and the treatment protocol. And the postoperative nursing diagnosis include the acute pain related to the surgical incision, catheter placement, and bladder spasm. Deficient knowledge about postoperative care and management. Next is the risk for infection related to surgical site, urinary catheter, and drainage secondary to imbalanced nutritional status. Last is the deficient knowledge related to medication, infection, preventive techniques, and signs and symptoms of complication. So the nursing responsibilities in a pre-operative nursing intervention is to reducing the anxiety. The nurse clarifies the nature of the surgery and expected post-operative outcomes, and relieving the discomfort. The nurse monitors his voiding patterns and watches for bladder distension and assessed with catheterization if indicated. And the nurse was providing the instructions. The nurse explains what will take place while the patient is prepared for diagnostic test and then for surgery. And last is to prepare for the patient. If the patient is scheduled for a prostatectomy, the preoperative preparation, anti-embolism stockings are applied before surgery and are particularly important to prevent DVT. If the patient is placed in a lithotomy position during surgery, an enema is usually administered at home on the evening before surgery or on the morning of the surgery to prevent post-operative straining, which can induce bleeding. So the postoperative nursing interventions would be maintaining the fluid balance. The patient is also monitored for electrolyte imbalances, increasing blood pressure, confusion, and respiratory distress. These signs and symptoms are documented and reported to the surgeon. Next is the relieving of pain. The patient assisted to sit and dangle his legs over the side of the bed on the day of the surgery. The nurse monitors the drainage tubing and irrigates the system as prescribed to relieve any obstruction that may cause discomfort. Next is the monitoring of managing of potential complications. After prostectomy, the patient is monitored for major complications such as hemorrhage, infection, DVT, catheter obstruction, and sexual dysfunction. So next is the promote home and community-based care. Teaching patient self-care. The patient undergoing prostectomy may be discharged within several days. The length of the hospital stay depends on the surgical approach used and may range from 1 to 2 days for robotic-assisted laparoscopic prostectomy to 3 to 5 days for open prostectomy. So the nursing diagnosis would be anxiety related to concern and lack of knowledge about diagnosis, treatment plan, and prognosis. Next is the urinary retention related to urethral obstruction, secondary to prostatic enlargement or tumor, and loss of bladder tone due to prolonged distension or retention. Next is the deficient knowledge related to diagnosis of cancer, urinary difficulties, and treatment modalities. Imbalanced nutrition, less than body requirement related to decreased oral intake because of anorexia, nausea, and vomiting caused by cancer or its treatment. Next is sexual dysfunction related to effects of therapy, chemotherapy, hormonal therapy, radiation therapy, or surgery. Next is the pain related to progression of disease and treatment modalities. Impaired physical mobility and activity intolerance related to tissue hypoxia, malnutrition, and exhaustion, and to the spinal cord or nerve compression from metastasis. So, lastly is the prognosis. That is the most important established indicators of prognosis for prostate carcinoma include the Gleason grade, the extent of tumor volume, and the presence of capsular penetration of margin positivity at the time of prostectomy. High-grade prostate cancer, particularly the percentage of Gleason grades 4 and 5 that are present, is associated with adverse pathologic findings and disease progression. Conversely, low-grade prostate tumors are infrequently dangerous. So that's all. Thank you.
Hey guys, thank you for watching. I hope you learned something. And before I end this video, don't forget to like, share, subscribe, and hit the notification bell for more upcoming learning videos. See ya. Bye.